just a bit of a caveat, just so that people understand. What I'm going to tell you about is work that we've done in BCU, looking at the scale and the risks involved in the prescribing of valporate in BCU. I am well aware that this work has been undertaken across other areas of Wales, and have been in contact with other health boards and the people leading the work around valporate in other parts of Wales. I think it's important to realise that probably, unlike previous presentation where there was plenty of answers, this presentation probably asks a lot more questions than actually gives us answers, but probably asks important questions which can be extrapolated beyond the use of valporate into the other drugs that we prescribe in a sort of across the interface in a shared care kind of way. There you go. So, as I say, this is work that's been done in BCU. That's a map of what BCU is. It's all of North Wales, 6 counties across North Wales. It's the largest health organisation in Wales, covering, obviously, like all the other health organisations in Wales, primary, community, mental health and acute hospital services, with 678,000-ish patients across those 6 counties. We've got a real mixture of some quite very deprived areas in areas of Denbighshire and Wrexham, and then the mixture from the urban areas of Wrexham, Flintshire, through to the rurality of Gwynedd and the sunny beaches of Anglesey. And, you know, because of some of the demographic we've got of some of the more deprived areas and one thing or another, there is that mixture of issues relating to poorer health outcomes in terms of medical and physical and mental health outcomes, and educational literacy issues, which can obviously be have an impact in epileptic patients. Okay, so the next slide is a very brief history of valporate, and I took these points from a timeline that was published as part of the Cumberledge report, which is 108 pages long. It's really, really interesting for somebody who likes timeline type things. And I think it was important to recognise that, you know, you can see in here valproic acid has been around for a fair old length of time and has been licensed initially in France. But even from its very early days, back as far as 1972, when it was first applied, where the license was first applied for in the UK, there were concerns about the use of valporate in pregnancy and the risk of birth defects. And this literally is part of the first page. The remaining 107 pages, it details all the various guidelines, changes, advice that's been created around the use of valproic acid and valporate to use it more safely in practice. So it's, you know, it's a drug that we know can be dangerous, and we have been using it for a long, long time, and we recognize those problems. And you can see as you go through this timeline how the guidance has strengthened from year to year, which is very interesting to sort of just see how this, you know, as I say, there was a license there granted in 1972, which was a very limited license because of the concerns around the lack of safety data. So this is BCU's historic valporate prescribing, and as you can see, it only goes back 6 years, but it's very level. We're not seeing a huge increase in its use, nor are we seeing a huge decrease in its use. So that begs the question, you know, obviously there are newer anti-epileptic drugs available, and obviously they're being used, but equally so, we're not reviewing those patients and maybe stopping it when these new alerts and risks are highlighted. And I guess that to some degree comes from the fact that for those of you who are experienced around review of epileptic patients, as soon as you start changing their medications, it has huge impact upon their way of life. Obviously, you change their medications, they therefore potentially have to surrender their driving licenses. It has a massive impact on their lives. So valproic acid is not growing in its use, but equally so, it's not reducing either. So most of you are familiar with those lovely shiny purple packs that those of you who've worked in community pharmacy will recognise well. So what are the risks? essentially, the risks for using valproic acid in or valporate in ladies who are of childbearing age is that if they become pregnant, 1 in 4 babies will be born with some developmental disorder. 1 in 10 will have birth defects. The types of excuse me, sorry, I've got my teeth in. The types of birth defects, things like spina bifida, facial and skull malformations, cleft lips and palates, malformations of the limbs and heart, kidneys, urinary tract. And there's also these longer term sort of developmental disorders that we don't know a huge amount about, but they're things like children will be later to develop, to learn to walk and talk. They sometimes affect their intelligence levels, their poor speech and language skills, memory problems. They're also more likely to be autistic and develop autism as they grow older, and develop ADHD and such like. So this work was undertaken in BCU. If I'm honest with you, and other people on the call on the meeting might know this, there seemed to have been, I would suggest, a conversation at the Wales Chief Pharmacists Group about the risks of valporate prescribing and the fact that as Wales we needed to be tightening up on or have some assurance about the implementation of the MHRA guidance, because a lot of areas in Wales seem to do this piece of work all at the same time. I would say other areas in Wales are perhaps slightly more advanced than Betsy, as in what are they doing about it? We're still in the early stages of moving into the looking at things like shared care. But essentially the new guidance, which actually came out in March 2018, said that valporate must no longer be used in any women or girls able to have children unless they're on a pregnancy prevention program. There was a almost complete ban of the use of valporate for the treatment of migraine and bipolar disorders during pregnancy, and it can only be used to treat epilepsy during pregnancy if there is no other effective treatment available. So they're really quite strong statements about where valporate can be used now, and it almost creates an urgency, I guess, around reviewing the appropriateness of prescribing valporate in all women or girls of childbearing age. So the pregnancy prevention program details are actually quite detailed, and it means that anybody prescribed valporate and who could become pregnant needs to have an expert review with around contraception, and this therefore makes the need for the shared care potentially more complicated, because usually with a shared care, and I'm happy to be stand corrected, is that it's the initiating consultant or clinician passes that shared care to the GP, whereas in this scenario we've actually got another specialist service that needs to be part of that shared care arrangement. The PREVENT programme is very comprehensive. It includes lots of, it's got a standardised risk assessment form that must be completed by a specialist with the patient to make sure the patient fully understands what they're signing up to. It's got literature that goes with it. It aims to make sure that it needs to be completed on an annual basis, and it needs to be signed off on each occasion. And it was put in place, I guess, originally for highly teratogenic drugs such as thalidomide and isotretinoin, and has obviously been extended to valporate. Within it, it states that the patient must be on highly effective contraception. So it defines in there that they must be sort of long-acting reversible contraceptions, contraceptives, coils, implants, etc., female or male sterilization. And that within that, you then get complex queries about, what about people who are sort of same-sex partners and people whose husbands had a vasectomy and one thing or another, do they need to be reviewed on an annual basis? And that's a whole question, I guess, that needs some more complicated discussion. But, there's a need for guidance, I guess, around those sorts of things. So what do we do in Betsy? First thing we did was we created a bulletin. We took the guidance, we expanded on that guidance, and we created a sort of local guide to how to implement it. We created template letters to enable GPs to refer patients back to specialist services where they needed referring back. We created a standard search that we ran across all the practices in BCU. We used slightly different criteria to what's used in the QAIF documentation, and in that we extended the age range. I think within QAIF it's 14 to 45, and we did 10 to 55, just because we wanted to make sure that we didn't leave any risk behind. And the search basically was any female patient who was on valporate, who was aged 10 to 55, who had prescription for valporate issued in the last 3 months, had no history of a hysterectomy, and no history of being postmenopausal. As I say, the interesting thing was we did make our population search a bit bigger, so we did find a few more patients, and I guess there needs to be consideration of whether that's appropriate or not. So what did we find out? So in BCU we've got 101 GP practices. 72 of them returned those, and there was a marked variation of where the returns came from. Some areas were far better at returning than others. From the 72 practices, we identified 243 patients. You can read all this on the screen. The worrying thing was the number of those patients who hadn't got documented annual risk assessments. So that's the annual risk assessment undertaken by the initiating consultant. And equally so, the other thing that was worrying was the number of these patients that didn't have a documented annual contraception review. Now, we weren't looking at them being on a pregnancy prevention program here. We were actually just saying, have they had a review of contraception in the last 12 months? And there were a lot of people where that wasn't documented in the GP surgeries, which got us quite worried, as you can imagine. And we did some sort of heartfelt digging around this and sort of thought, well, what's going on here? And I guess it comes back to that old issue of, data's only as good as data. We were asking practices to run a search and identify it had been coded. And I guess the first part of quality improvement is to establish if the data that we're looking at is actually quality. It may be, we were looking for specific read codes, and it may be those reviews had been done but hadn't been coded effectively. So I guess when we rerun this audit this year, we would hope that these numbers have improved and the performance is better, because actually in the first place the coding's improved and the work had been done, it just hadn't been coded properly. So we wrote out to all the GPs and across North Wales, making them aware of our concerns, making them aware of what we felt was an expectation. We recognise that there is far more work that needs to be done about engaging our consultant colleagues, particularly mental health and neurology. We have quite complicated relationships in North Wales. Mental health obviously is a North Wales hosted service, but our neurology services are provided from Walton, which is in Liverpool, across the border. So that's a more complicated relationship to try and manage. And with regards to reviewing of epileptic patients on valporate, so there is significant amount of work for us to do in North Wales that will be different for different practices of different areas across Wales. So to be honest, we're at a point now where we've kind of got an idea of the scale of the problem. We're kind of at a position where we're realizing the work that we need to do. And it was very interesting to talk to colleagues in South Wales that they've done very much the same piece of work. They've recognized the size of the problem, and they are perhaps slightly, as I say, further ahead than us in the process of what do we do to put this right. As I say, Audit Plus identified 188 patients across North Wales from 100% of our practices. We estimate there's probably more like about 300 with the wider, 330-ish from the wider search that we ran. And so there needs to be a discussion about what we which patient groups, how we define our patient group. So as I say, these are the actions we undertook. We wrote to all the GP practices. We highlighted our concerns. We've told them that in the short term, we recognise that there's a gap in service quality because of COVID, and actually accessing some of these services, it's quite difficult. But also in the, sort of do what you can while we help us out, and do what you can whilst we sort out the access to sexual health services, reviews of mental health patients, and agree shared care agreements with the different consultant body or consultants that need to be involved. And we will re-audit it this year and see what happens. So I guess bringing us on to what have we learned, the significant challenges in all this. I think one of the first and most significant challenges is data. We rely in primary care very heavily on read codes. Those of you who've worked there will know all about these. Read codes are very, very good, but different practices use read codes in different ways to code different conditions using different codes. There's also a whole load of EMIS and Vision local codes, which are also used quite a lot. This can make it difficult for things like us to pull data consistently, because if we don't code data consistently, we can't drag it out of the systems effectively. There's also no searchable database that exists in North Wales from a consultant, from a specialist, from a hospital perspective. So there's no way that our mental health consultants, for instance, at this moment in time, don't know who their bipolar patients are who have been treated with valporate. They've initiated them, they've handed it over, even though there's shared care. Well, there isn't shared care. They don't know who they are to bring them back, to review them, or to undertake that shared care review. And I guess that's exactly the same from a neurology service perspective. So we've got huge issues around the data. The patients are a complicated group of patients. It's very broad. Patients who are being treated, certainly for epilepsy, there's an increased proportion of that population who have learning disabilities. And therefore, patient information needs to be very well written, very well targeted to help them understand the risks associated with valporate in pregnancy. There's also complicated questions, I guess, when you're looking at under 16-year-olds who potentially been treated with valporate for epilepsy and maybe having learning disabilities, but also being accompanied by parents to reviews, and having open conversations with them about their sexual activity and whether or not they're sexually active, about putting them on pregnancy prevention programs, which is where I guess we need to bring in the specialist family planning or sexual health services, because they're more adept at those types of conversations. And then the annual requirements for PPV review, there's no caveat within the guidance around that for ladies who've had hysterectomies, or for same-sex relationships, or ladies where the partners have had vasectomies. And I guess we will get challenged from patients who are in, whose partners had a hysterectomy or one thing or another. Why do I have to have this review every year? Because it's not relevant to me. And I guess, we need stronger guidelines around that. The hysterectomy one is fairly clear cut. If you've had sorry, that wasn't meant to be a terrible pun. That was, if you've had a hysterectomy, you can't become pregnant. But if your partner's had a vasectomy, you may separate and have a new partner, in which case you do need that review, because that needs to be reiterated on a regular basis. Thinking about specialists, we need clear guidance about which specialists are required to do which parts of this review. Obviously, we've got the initiating specialist has to do the annual review about, is this still appropriate and the most efficient drug treatment for managing this patient's condition. But as I've already said, we need to bring in family planning specialists within this pathway about how this is managed. There's also the issue, I guess, of there's never enough service provision to go around, is there? We're looking at 388 patients across BCU. We think our conversations with mental health colleagues have been, we would like to review those patients and actually consider stopping the patients who are mental health patients on valporate, because there are newer treatments available, which is also, true for epilepsy patients. It's about it's a patient a day maybe that needs to be reviewed. That's quite an increase in capacity, and how are we going to make that happen within the current restrictions? I think also there's probably a huge amount of awareness that needs to be and training that needs to be given to clinicians about the risks of valporate. I mean, certainly I didn't realize quite how, although I admit I am no expert, we know that valporate causes problems or is risky for use in pregnancy, but I don't know that we need to do a lot of publicity and retraining about how great the scale of that risk. And as I say, communicating that risk effectively to patients who potentially have learning disabilities or are young people and teenagers is a difficult thing to do. We need training for GPs and prescribers, and that's all prescribers. We've got our North Wales service consists for epilepsy consists of epilepsy specialist nurses. So there's a big piece of work to do there. We've got a real issue. There always used to be a caveat that I was aware of, and I'm not sure everybody is. And the question is it still true? There was always a comment and that a pregnant patient managed well on valporate is a safer pregnancy than a pregnancy unmanaged on no treatment. And I don't know whether that's true anymore, because looking at the rates of harm, is that still a relevant caveat to go by? Sorry, lost my page. So recommendations, I think from what we're trying to work at in North Wales, we're trying to come up with some sort of comprehensive education programme for our healthcare professionals across North Wales so that they understand the risks, they're fully aware of the need for patients to be reviewed in line with this guidance, but also from a point of view of not just is the patient okay now, but should we be looking to change drugs, and having those conversations with patients and being able to effectively communicate that risk, which comes into patient information. So we need to look at really good, effective ways of communicating these risks to patients. A leaflet is not good enough. My colleagues in public health years ago told me that something like for every 100 leaflets you print, 99 go straight in the bin, 1 gets read. So, leaflets are not always the most effective way. We need to explore other methodologies of communication. Maybe it's, smiley face charts, maybe it's YouTube videos, maybe it's, all sorts of different options that we need to look at to get that effective measurement across, in communication across. I think we probably need to have sort of standardization of the data, and I don't know whether there's an opportunity to issue almost an edict across Wales that all the codes relating to valporate and risk assessments will be the following codes, and GPs are paid an enhanced service to make sure they use the correct codes, because at the moment the extraction of data is difficult, and I know that Quaif will hopefully help identify the patients where the data is missing and tidy it up, but there needs to be some sort of data quality standard so that we can manage the data elements of things, and that would apply to not just GPs but to the acute as well, to make sure that they're coding things in the same way. And I think that the most complicated thing of this, and as I say, that we rely a lot on paper still in the NHS. We write letters to people. We have shared care agreements that you sign and print off and email to people. I think there's a time where we should be starting to think about a clever integrated IT approach to the management of particularly this valporate shared care issue, because we do need to create a shared care protocol for valporate. But it's not just the initiating prescriber and the GP. There is this third part of a sexual health review needs to be included in there. And I think we do need to consider how do we create almost an online database of all the people prescribed valporate in Wales. It needs to obviously record patient details, in the indication, the drugs, who the initiator are, so who's the responsible clinician, who's the responsible GP, who's the responsible sexual health clinician. And it needs to be a live database. It needs to be accessible across all of healthcare with the appropriate, as appropriate. So it could be a database that sits centrally held that, you know, when the consultant initiates it, they enter the patient onto their sexual health, enter their data onto their GP, takes it over, but also available to people such as the community pharmacists to be able to check that database to make sure that at the point of issuing of valporate prescriptions, they can check to make sure that all the right things are in place and the patient's safely managed. And I think, you know, those of you who work in primary care know that shared care is a huge burden for GPs and for secondary care. And once we got something like this working around valporate, what's to say we don't extend it to other shared care drugs? You know, 12 months ago, 18 months ago, 2 years ago, there was all this stuff about lithium brands being discontinued. And we have the same problem with our mental health services of they didn't know which patients were on lithium. If we had a shared care database as such, it would be far easier to pull all that data together. So I think that's pretty much where I'm up to. As I say, a lot of this work is, I would say, progressing far quicker in South Wales with colleagues in Cardiff and Cwm Taf than it is in BCU. And actually part of preparing this has made me contact them and realise just how much work there is that we've not done yet in BCU. We've really scraped the surface of finding out how big the problem is and what needs to be done. And I guess my sharing this with yourselves is to highlight that actually it is a big problem. There's a huge opportunity from if we use this as a lever to improve things, to then use it as a template to move forward along a wider range of shared care issues, because increasingly as our population becomes more complicated, as we have more and more people being managed in primary care rather than the acute, we need those comprehensive databases of shared care. So I think that's probably about it. If not any questions, I'm happy to take, but as I say, more questions than answers, I'm afraid, for this one. So thank you.